Greetings of peace and good day, students. So today we will discuss coping with loss, grieving, and death. So this is the unit 6 of our subject, meeting the needs related to death, dying, grief, and grieving. It is an important topic in nursing because nurses frequently care for patients and families experiencing loss. So, in healthcare settings, nurses are often present during illness, dying, and death. Therefore, it is important for nurses to understand the emotional responses of patients and families and how to provide compassionate care during these times. So, our role as nurses is not only to provide physical care but also to support patients and families emotionally, psychologically, and spiritually during difficult times. So, let's start with coping with loss, grieving, and death. Now, we have to define some important terms related to loss and grief. First, we have here loss. It is an actual or potential situation in which a valued object, person, or the like is inaccessible or changed so that it is no longer perceived as valuable. So, or in other terms, or another definition, it is defined as an actual or potential situation in which something is valued, such as a person or object, becomes unavailable or change. And loss can occur in many forms, not only through death. Example, a person may experience loss when a loved one dies. A person loses a job. A patient loses a body part after a surgery, or a family loses their home due to a disaster. Now, we have here another term. We have bereavement. Bereavement is the subject response to a loss through the death of a person with whom there has been a significant relationship, or it refers to the subjective emotional response experienced when a loved one dies. Okay? So it is it describes the period of mourning and adjustment after the death of someone significant. Okay? Example, a daughter who loses her mother may experience sadness, loneliness, and emotional pain. And this emotional response is what we call bereavement. Next, we have here grief. So what is grief? It is the total response to emotional experience of the loss and is manifested in thoughts, feelings, and behavior. Or again, it is the total reaction towards loss. Okay? So people express griefs in different ways. Some may cry openly, while others may become quiet or withdrawn. So example, a husband who loses his wife may cry frequently, feel depressed, or lose interest in daily activities. And that is grief. Next, we have here your mourning. Okay? Mourning is the external expression or the behavioral process through which grief is eventually resolved or altered. It is often influenced by culture or custom. Again, mourning is external expression of grief, often influenced by cultural and religious tradition. Example, we have different cultures practice mourning differently. Some cultures hold funeral gatherings and prayer services, while others may observe specific mourning or rituals or clothing. Example, in Christians, you experience or you have funeral gatherings while the dead body is in a coffin. While in the Muslims or practicing Islam, the funeral gatherings are done without the body of the dead person. At the time the patient or at the time the person died, they will be buried. Okay, after doing cleansing, okay, of the dead body, they will automatically be buried, okay, in the soil. Okay, while as here sa those non-Muslims or Christians, they do funeral gatherings with the body present. Okay? So we have different rituals or clothing, specific clothing that we use. Okay? So the development of concept of death. The concept of death from a child's perspective is very different from an adult's understanding of death. Furthermore, as the child grows and matures, his or her early ways of thinking about death will change. It's essential for adults to have a sense of how children conceptualize death at different ages so that when the time comes to talk about death, whether a pet or a loved one, adult can respond in a manner. So understanding death changes as a person grows and matures. Okay? So that's why by understanding by knowing that they have different concepts on death, we know how to deal with them. Okay? So example, young infants to birth until 1 year of age, up to 6 months, a loss brings no response due to undeveloped memory capacity for specific personal relationships. So they don't know what's the feeling of being having loss of loved ones. Up to 6 months, there is no ability to conceptualize death. From 6 months to 1 year, a loss like separation may be felt, if at all, as a vague or absence or experimental sense of something different. So the baby or the infant may experience crying, but then later they will be able to adopt. Okay? So older infants such as 1 to 2 years of age, the death of the primary caregiver will usually result in displeasure and depression. Okay? Example, the primary caregiver is the mother or the father. The loss of mother or father for the child is displeasure or a depression. Okay? Although a loss may occur, there is no ability to understand or attribute meaning to it. Infants can be influenced by by parents' tense and emotional grief reactions to a death of in the immediate family. For 2 to 6 years of age, death is understood as a temporary and reversible. They do believe that after an individual passed away, they will come back as again. Okay? There is no concept of personal death, and death is something that only happens to other people. They don't know that death happens anywhere, everywhere, and whomever. Okay? Dead persons or animals are broken and can be fixed or asleep and can be awakened or gone and will be back. So their concept is that temporary and reversible. They will come back. All of the dead person, all of the dead animals will come back. And well-developed 4 to 6 years old often think about and are quite interested in death and often want to see, touch dead things. For 6 to 9 years of age, from 6 to 8, a clearer understanding of death is developing. There's an increased interest in the physical and biological aspects of death. Magical thinking predominates with the belief that thoughts can make things happen, even accidents and death. By 9 years of age, the child's concept of death is very similar to an adult. Death is not reversible or temporary, but only happens to some or other people. So here, yes, the child believes that death happens. However, he or she still believes that it only happens to other people and not with their family or with themselves. So death is often thought of a person as a ghost figure. Okay? For 9 to 10 years of age, child's concept of death expands to that held in adult life. Awareness of the possibility of personal death is now fully developed. An objective curiosity develops. What does the body look like? Is the blood blue? The body is stiff? Cold? Even though there is a cognitive awareness of death, and its universality and finality, there is a strong tendency towards denial. So even though they have a fully developed understanding of the death, they do still have denials toward it. Okay? There is an increased interest in what happens after. Okay, so that was the different stages, development of concept of death. So until you reach the age of 13, 14, 15, so you were young adults, okay, teenagers, then you will have a fully and mature developed idea of death. Okay? So for nurses, it is important to communicate about death according to patient's age and level of understanding. So in doing so, you can help the patient coping with the death or with the loss, and then you can help them mourn towards the towards their loved ones. Okay, so we have here stages of grieving based by Kubler-Ross model. Kubler-Ross, a Swiss psychiatrist who first introduced her stage grief model on her book on death and dying. Kubler-Ross model was based on her work with terminally ill patients and has received much criticism in the years since. So, Ross developed the 5 stages of grieving, such as we have your DABDA. D stands for denial, A stands for anger, B stands for bargaining, D stands for depression, and A stands for acceptance. These stages describe emotional response often experienced by people facing death or major loss. So, based on the Kubler-Ross grief cycle, it starts from denial. Denial occurs when a person refuses to believe or accept the reality of loss. So the patient experiences avoidance, confusion, elation, shock, or fear. So, example, a patient diagnosed with terminal cancer might say, "This cannot be happening to me." So, denial serves as a temporary defense mechanism that helps people cope with overwhelming emotions. After denial stage, here comes the anger stage. As you can see, the emotion medyo it will decline. Okay, the anger stage, during this stage, the person may feel anger or frustration. They may direct their anger towards healthcare providers, family members, or even themselves. So the patient may experience frustrations, irritations, and anxiety. So be careful in handling those patients because they may direct their anger towards you. So you have to you have to give them time. Okay? So a patient may say, "Why is this happening to me?" Or a family member may blame doctors or nurses for the illness. After the anger stage, we have the bargaining stage. The bargaining occurs when a person attempts to negotiate or make promises in hopes of changing the situation. So, they will ask, maybe there's a chance of or possible that they will be revived like this, like that. Okay, so they will bargain, they will struggle to find meaning, they will reach out to others and telling one story. So a patient may pray or say, "If I recover from this illness, I will change my life and become a better person." They will bargain, they will, okay, in exchange of this life, please, I will give you all. Okay, so they will bargain. After bargaining stage, we have depression. Depression occurs when the person begins to realize the reality of a loss, leading to sadness and withdrawal. A person will now feel overwhelmed, helplessness, hostility, and flight. They may flight from stress, okay? They will look for any way to feel not depressed, okay? So, a terminally ill patient may cry frequently or lose interest in conversation or activities. Then, the last stage of grief cycle by Kubler-Ross, acceptance. Acceptance occurs when the person comes to terms with the loss. This does not mean that the person is happy about the situation, but they have reached a state of emotional peace and understanding. Okay, I understand that everybody experience death. Okay, we will come there. It's their time. It's not yet my time, so I have to wait for my own time. So the individual will explore options. They will have new plans in moving on. Okay, so a patient may begin discussing final wishes or expressing gratitudes to their family. So during this grief cycle, information and communication, emotional support, and guidance and direction is very important from the nurse. Okay. So another grief model that we use is Martosho's 5 clusters of grief. Okay. So here, it is similarly the same or similar with the Kubler-Ross grieving or grief cycle. So it starts with shock and disbelief, wherein you may feel numb, anger, sadness, guilt, and many may deny loss. After shock and disbelief, you will experience yearning and protest, or anger and withdrawal. After that, you will experience anguish, disorientation, and despair. There's a decreased interest in the future. Decision making is difficult for him or her. He may feel or she may feel lack of purpose in living and commonly crying. After that stage, they will come to identification in bereavement. They may imitate deceased habits, traits, and goals. After that, they may experience reorganization and restitution. Grieving does not stop at once. Typical patterns of life return, but no timetable can be set. So, grieving of a loss, or grieving or bereavement or mourning of a loved ones depends on a person. We have no specific timetable where a person can accept, can reorganize, and restitute their emotions, their feelings, and we can never tell when a person can move on and heal from their past experiences. Okay? So another model of grief, we have Engel's stages of grieving. So it's more on similar to what Martosho's 5 cluster of grief is. So we have shock and disbelief, we have developing awareness, we have restitution, resolving the loss, idealization, and outcome. For shock and disbelief, an individual refuses to accept loss and has stunned feelings. Developing awareness, the reality of loss begins to penetrate into consciousness. Anger may be directed and to agency, nurses, or others. Restitution, it conducts the person conducts rituals or mourning or funeral. Then after resolving the loss, attempt to deal with painful void. Makes accept more dependent relationship with support person. For idealization, they produces images of lost of an object that is almost devoid of undesirable features, and reinvest feelings in others. While the outcome is the last wherein the individual accepts the reality of loss. Okay? So now let's talk about the different symptoms of grief. Okay? So first, grief can affect, take note that grief can affect a person's physically, emotionally, and psychologically, in which common symptoms may include repeated somatic problems, tightness in the chest, choking or shortness of breathing, sighing or crying, empty feeling in the abdomen, or what we call I forgot about that term, but you feel empty. Loss of muscular power or loss of energy, or intense subject distress, or feelings of emptiness and sadness. So a person grieving the death of a spouse may experience difficulty sleeping, loss of appetite, and fatigue. And these symptoms are normal reactions to loss. Okay? So you have to identify that one, and then you have really, by knowing that, you will learn that the patient is experiencing grief and not a specific disease. Okay? So, how can we assist clients with their grief? So, nurses play an important role in helping patients and families cope with grief. One important approach is to allow people to express their feelings and share their experiences. You will provide opportunity for the persons to tell their story, recognize and accept the varied emotions that people express in relation to a significant loss, to provide support for the expression of difficult feelings such as anger and sadness, include children in their grieving process, encourage the bereaved to maintain established relationship, and acknowledge the usefulness of mutual help groups. For example, if a patient begins talking about their fears of dying, the nurse should listen attentively without interrupting or changing the topic. The nurses should also accept different emotional responses such as anger, sadness, and silence. A grieving family member may become angry or blame the healthcare provider. The nurse should remain calm and recognize that anger is a part or a normal part of grief. So, providing emotional support and reassurance helps individual process grief in a healthy way. Okay. So, these are different nursing diagnoses that we can come up or we can implement with clients with grief and loss. First, we have anticipatory grieving related to, okay, depending on what is the etiologic factor. We have also dysfunctional grieving related to. We have impaired adjustment related to, and social isolation related to. So I cannot give related to because we have to specific what is the problem. If it's loss, if it's grieving, if it's mourning or bereavement. Okay? So now, let's talk about the care of dying client or terminally ill patient. So how do we care for those clients? So dito naman, if the previous part of the unit is talks about how do we handle more on the family members by identifying their also by identifying the different models of grief. Now let's understand how we can take care of those people who experiencing at the terminal illness or patients who are dying. Okay? So we have here what we call end-of-life care. This type of care focuses on physical and psychosocial needs of the person and their family. It focuses on providing comfort and support to patients who are approaching death. So their main goals of this care is to provide comfort and supportive care during the dying process, improve their quality of their remaining life, and help ensure dignified death. Okay? So by supporting, this may include also supporting their emotional and spiritual needs. So for example, for a terminally ill cancer patient, the nurse may focus on pain management, emotional support, and maintaining comfort rather than aggressive treatment, especially if the patient is on the stage 5, okay, late stages of cancer. Definitely we are more focused on palliative care. Okay? So, death occurs when all vital signs and systems cease to function. It is the irreversible cessation of circulatory and respiratory functions, or the irreversible cessation of all functions of the entire brain, including the brain system. So we have here different signs of impending death. Okay, so a care for dying client, you have to know what are the different signs of impending clinical death. First, there will be loss of muscle tone. Okay, so this may indicate that the death is approaching. There will be limited ROM. The muscle strength will become 3/5 or 2/5, 1/5. There will be slowing circulation. There will be changes in vital signs. And lastly, there will be sensory impairment. For example, hearing is often believed to be the last sense to disappear, which is why healthcare providers encourage family members to speak gently to the patient even if the patient appears unconscious. So, total indication of death, total lack of response to external stimuli, no muscular movement, no reflexes, or a flat EEG. So, other signs actually may include cold, clammy skin, of impending death, okay, irregular breathing, decreased urine output, and weak pulse. So, these changes occur because the body systems are gradually shutting down. Okay. So, another indication of death, such as physical manifestation, okay, the sensory system, the hearing usually last to go, touch, decreased sensation, and perception of pain and touch is decreased. So decreased with taste and smell, okay? Blurring of vision, glazing of eyes, blink reflex absent, and eyelids remain half open. For the integumentary system, there will be mottling on the extremities, cold clammy skin, cyanosis on the nose, nail beds, and knees. For respiratory, there will be an increased respiratory rate, usually Stokes breathing, wherein there is a period of apnea, or meaning absence of breathing, and deep rapid breathing. Inability to cough or clear secretions, causing grunting, gurgling, or noisy congested breathing. Irregular breathing, gradually slowing down to terminal gasps. For urinary system, there's a gradual decrease in the urinary output and incontinent of urine or unable to urinate. For the GI system, slowing of GI tract and possible cessation, accumulation of gas, distension, nausea, incontinence due to loss of sphincter control. Basal metabolism may occur before imminent death or at the time of, bowel movement may occur before imminent death or at the time of death. For musculoskeletal system, gradual loss of ability to move, sagging of jaw resulting from loss of facial muscle tone, swallowing can become more difficult, difficulty maintaining body posture and alignment, loss of gag reflex, and for a patient on large doses of pain medication, might see jerking. For cardiovascular system, increased heart rate, later slower and weakening pulse, irregular rhythm, and decreased blood pressure. So, a dying person may need to talk. There are some things they might not want to discuss with their family. So, you have to allow them to express their feelings, to share their worries and concerns. Just be there. You don't need to talk, no? Silence is okay and therapeutic touch is okay. Your personal attitude about death will influence the way you provide care. So that it's always that you know your personal attitudes and self-awareness about death. Report any abnormalities to the nurse. Okay? So for the family of the dying person, you may need to talk to them to allow them to express their feelings, share worries and concerns away from the dying patient. They may just need you to listen. They may require a private area to talk and make their decisions. The focus is often on the patient and they often neglect their own needs. They may need to get them pillows, blankets, or a place to sleep, meals if necessary, and chaplain visits. Report anything significant said by the family to the nurse. So different services may available for patients such as palliative care. We have active total care of individuals whose diseases is not responsive to curative treatment. So this focuses on relieving pain and managing symptoms for patients with serious illnesses even if they are still receiving treatment. So example for this one is a patient with advanced COPD may receive medications to relieve breathing difficulty and improve comfort. So another services, we have hospice care. So this is for the terminally ill patients. We provide compassion and support for dying patient and family. So this is designed for patients who are terminally ill and expected to live only a limited time. It provides medical, emotional, spiritual support or for both the patient and the family. So example, a terminal cancer patient that may receive hospice care at home surrounded by family members while healthcare professionals manage pain and provide support. So another service may include home health or chaplain. Okay? So hospice care involves a team-oriented approach from expert medical care, pain management, and emotional and spiritual support expressly tailored to patients' needs and wishes. Support is provided to the patient's loved ones as well. At the center of hospice and palliative care is the belief that each of us has right to die pain-free and with dignity, and that our families will receive the necessary support to allow us to do so. So, what are the nursing interventions for a dying client? First, assist the client to achieve a dignified and peaceful death. Maintain physiologic and psychologic comfort, and provide spiritual support. So, nursing responsibilities may include comfort measures to provide for a family and person at the end of the life, such as pain management, bath, or reposition. You can provide music, touch, holding a hand, gentle massage, hand on visitor's shoulder. Religious needs may include visit from chaplain or reading of scriptures or Bibles or Quran. Snacks and drinks for visitors, supportive presence, and non-aggressive medical treatment. Another is removal of non-surgically inserted tubes and devices from post-mortem person. Post-mortem care begins when the person is pronounced dead. Maintain privacy and treat with dignity. Done to maintain good appearance of the body. Discoloration and skin damage are prevented. Bath patient as needed, often incontinent. But again, depending on the culture, we have to respect that, depending on the wishes of the family. Position body and normal alignment, because rigor mortis begins 2 to 4 hours after death. So, rigor mortis, it will cause stiffness or rigidity of skeletal muscles. So, removal of non-surgically inserted tubes and devices. Some patients have to be cleared by medical examiner and cannot have tubes out until cleared. So, when we talk about dying patient, we have to assess also if the patient is a organ donor, because there are some of our patients who have a ID or identification that he or she is an organ donor. So, the decision to donate may be made by the person before death or by immediate family members after death. So, nurses may delegate specific tasks as allowed by PMP. So now let's talk about post-mortem care. What are the things that we do in taking care of the dead body? Okay? So, first, let's have understanding first of what are the changes that occur during or after death. So, after death, decomposition of blood cells causes appearance of bruising and mottling of the skin. The ATP production stops, myosin heads become stuck to the actin, and rigor mortis sets in, making the body stiff. Post-mortem care should be done as soon as possible after death to prevent tissue damage and disfigurement. So, the nurse must ensure that the body is treated with dignity and respect. Okay? So, what are the body changes that have been mentioned? So, we have here rigor mortis, algor mortis, and livor mortis. So, first, the body changes result to stiffening of the body due to chemical changes in the myofibrils. So, about 2 to 4 hours after death, the muscles become stiff. After rigor mortis, the algor mortis happens. Okay? There is a change in the body temperature until the ambient temperature is matched, or gradual cooling of the body. After algor mortis, livor mortis happens, also known as your hypostasis. Meaning, it is the pooling of blood in the body due to gravity and the lack of blood circulation as a result of the cessation of cardiac activity. So, what happens here? The blood will pool in the lower parts of the body due to gravity. And these changes occur naturally after death. So, what are the things that we need to implement or intervene for the body, or how do we take care of the body after death? Make sure that the environment is clean, as pleasant as possible. Make the body appear natural and comfortable, okay, by cleaning all the body and positioning the body properly. Removing all the equipment and supplies from the bedside. Remove soiled linens so the room is free from any odors. Place the body in the supine, the arms at the sides, and palms down. But again, the positioning may vary per culture because they some culture prefer positioning the arms at the heart or heart level. Okay, some will making a fist or what depending on the culture, so you have to ask them. And then you may allow family members to view the body. Place one pillow under the head and shoulder. Close the eyelids, insert dentures, and close the mouth. But then, not all cultures allow dentures. So some will tell you that you have to remove the dentures. Wash soiled areas of the body. Place absorbent pad under the buttocks to take up any feces or urine released. Provide a clean gown, brush or comb the hair. Remove all the jewelries. Allow the family to view the patient's body. Apply ID tags and wrap the body in shroud. And bring the body to the morgue. But then again, depending on culture. Because some cultures do not allow bringing the body to the morgue directly, they wishes the body to be removed from the hospital and then brought up in at their homes and where they will perform the post-mortem care. So for post-mortem care, prepare the body for the family to see if they wish to. Be sure the body is clean. Prepare body so deceased appears comfortable. Turn off monitors and etc. Check if autopsy is to be performed. If so, do not remove any lines or tubes. So, if the patient, example, the patient died because of a murder or attempted murder, so autopsy is needed. So, you have to identify if the body should be or should undergo autopsy. So, allow family members to stay as long as they wish. Offer to call chaplain, clergy, friends, or other family members or imam, okay, for Islams. Determine whether patient is an organ donor prior to clinical death. Make sure the patient is not to need to be kept alive until organs are harvested. So the patient will be placed in ano to? What do you call this? Life supports, okay? Life support machines. After family has left, the nurse prepares the body for transport to the morgue or pick up by funeral doctor. Check if family wants to assist in caring for the body. So, for the procedure of your post-mortem care, first, verify identity, notification of family and or clergy. Determine if autopsy is to be done. Determine if family would like to assist in bathing the deceased. For planning, gather equipment, bathing supplies, clean linens, gown, post-mortem kit. Assist roommate out of the room. Provide privacy. Plan to handle the body with dignity and care. For implementation, close door and curtains for privacy. Treat body with dignity and sensitivity. And try to perform post-mortem care as soon as possible to prevent tissue damage or disfigurement of body parts. So for doing the post-mortem care, wash hands and don on gloves. Position the patient in a supine position with a small pillow under the head. This prevents lividity or discoloration of the face from blood pooling. Replace dentures, maintains normal facial features. Close eyes and mouth. Place a rolled towel under the chin. Okay? Para hindi nag-open yung kanyang... So that their mouth will be will be closed properly. Okay? Remove jewelry and clothing. Give to family and document. Wash all areas soiled with blood, feces, urine, and drainage. Place pads under the rectum and between legs. After death, sphincter muscles relax, allowing leakage of stool, urine, or body fluids. Comb hair and arrange neatly. Remove all tubes, IVs, catheters, etc. if no autopsy to be performed. Change soiled dressings and remove adhesive marks with solvent. Dress body in clean gown, and if the family to view, remove gown before placing in shroud. Attach ID tags on big toe or ankle and wrist. Place padded ties around ankles, crisscross wrist over abdomen, and secure with padded ties. Place a gauze tie or chin strap under the jaw to keep mouth closed. Place the body in a shroud and check for placement of drainage pads. Fold shroud, secure shroud at chest, waist, knees, and place ID tag on outside of the shroud. Transfer body to stretcher or morgue cart. Transport to morgue per facility policy. Use discretion. Respect disease needs and needs of other patients. For documentation, it must be objective, complete, legible, and accurate. Legal proof of nursing care must be provided. Record who was present at the time of death. Last entry should state where and to whom the body was transferred. Para if in case the family members will ask, where did you endorse the body, like that, so forth. Okay, because there are some who tries to steal dead bodies to be used for studies and further researches. So you have to check on that. Okay? So in summary, loss and grief and death are universal human experiences that affect patients and families in many ways. As nurses, it is important to provide compassionate, respectful, and holistic care during this situation. By understanding the grieving process and providing emotional support, nurses can help patients and families cope with loss and experience dignity at the end of life. So that would be all. Thank you for watching and wassalam.